Good afternoon, my esteemed colleagues. My name is Dr. Nora Bassam Khoury, and I'm currently a second-year endocrinology fellow at Larkin Community Hospital in Miami, Florida. Diabetes insipidus is an uncommon disorder with a low prevalence of 1 in 250,000 people. DI involves deficient production or lack of effective action of antidiuretic hormone. ADH stimulates the kidney to conserve fluid. Deficient production of ADH or lack of effective action of ADH causes a high urine output, increased thirst, dehydration, and low blood pressure in advanced cases. Patients presenting with increased polydipsia and polyuria should be evaluated for possible causes of increased diuresis such as diabetes insipidus. I will be presenting a case today on a patient in which I encountered who was admitted to my institution during my first year of fellowship. The patient was a 57-year-old male ALF resident with a past medical history of hypertension, BPH, schizophrenia, autism disorder, and COPD, who was admitted for altered mental status, aggressive behavior, and urinary incontinence. The patient had been recently admitted at another hospital due to aggressive behavior with excessive water intake. During that admission, he was found to be hyponatremic with a serum sodium of 120, worked up for acute urinary retention, which resolved with a temporary Foley catheter placement, which was removed just before discharge back to his assisted living facility. 24 hours after being discharged, the patient was brought back to Larkin and admitted for urinary retention. All of his labs, including electrolytes, serum osmolarity, were within normal range, and his vital signs remained stable throughout his hospital admission. The urinary retention resolved spontaneously without any intervention, and the patient was then discharged back to his ALF. 4 days later, per the ALF owner, after the patient had returned home, he became agitated and was not sleeping. He had been destroying items and broke a toilet trying to drink water from the toilet tank, and at that time was brought back to Larkin Community Hospital and admitted for evaluation. Per the patient's mother, the patient has had excessive thirst and urination for the last 2 years. She reports that these symptoms started in 2018 after being discharged from another facility where he was admitted for severe hyponatremia, and during his hospitalization, he developed seizures concurrently. The patient's home medications are clonazepam, diltiazem, lisinopril, lorazepam, mirtazapine, quetiapine, risperidol, and temazepam. Due to a high clinical suspicion after ruling out the other common causes of polydipsia and polyuria, the water deprivation test was done. The principle of water deprivation test is to assess the ability of the patient to concentrate urine when fluids are withheld. Water deprivation should normally cause increased secretion of ADH, resulting in the production of small volumes of concentrated urine. During the patient's admission, a 24-hour urine collection was done, and 2,600 cc's of urine was collected. Next, a water deprivation test was done, and the following protocol was ensued. The duration of the first portion lasted 8 hours, from 6 a.m. to 2 p.m. The patient was made NPO, his bladder was emptied, and the urine volume, urine osmolarity, urinalysis, vital signs, and patient weight was collected and recorded every hour, and serum osmolarity was collected and recorded every 2 hours. After completion of the 8-hour water deprivation portion, it was found that the patient's urine osmolarity failed to become more concentrated, ruling out primary polydipsia. Thus, the 4-hour desmopressin test was then done. First, 2 milligrams of desmopressin was administered IM, and then weight, urine volume, and urine osmolarity were obtained every hour over the next 4 hours. Complete central diabetes insipidus is diagnosed when you have more than a 50% increase in the urine osmolarity after giving vasopressin, or desmopressin in this case. In this patient's case, the urine osmolarity increased after the desmopressin was administered, but the increase was less than the 50%. Therefore, a diagnosis of partial central diabetes insipidus was made. In general, patients who present with polydipsia and polyuria, even with psychological or psychiatric history, should be evaluated for possible causes of diuresis, whether it be glucose-induced, primary polydipsia, or diabetes insipidus. The diagnosis of diabetes insipidus is very challenging because it relies on laboratory values, urine output, and patient compliance. In our case, the challenges were the patient's autism and limited ability to cooperate with multiple parts of the workup. When confronted with multiple challenges, it is imperative to create an integrated team to increase the chances of successful completion of the test in its entirety and accurate results. It is crucial and important to identify the cause of diabetes insipidus and to implement therapy as early as possible to prevent the electrolyte disturbances associated with mortality and morbidity. Thank you very much for listening to my presentation, and have a great day.